Good evening, everyone. Thank you so much for joining us today on the Shock Talk. Shock Talk is all about shockwave with our women cardiologists, Indian cardiologists today with us. Before we start the event, let's talk, few things regarding Translumina. So as you all know that Translumina is now available worldwide and we have sold approximately 1 million implants so far, not only in India, but Europe, Africa, Latin America, and Asia. And we have our global acceptance in approximately 50 countries. We are the only company with the world's first 10 years clinical data of safety and efficacy of two of our flagship products, Yukon Choice PC and Vivo ESAR. These are the products which are available in each and every cath lab in India as well. Other than that, we have a complete range of portfolio and devices which are available in your cath lab. We have strategic partnership with Sys Medical from Switzerland for OPNNC and Nick Nano, ABioMed from Singapore for Impella, Shockwave from USA for Shockwave intravascular lithotripsy, and Shockwave will be the topic of interest today. Other than that, when we talk about the awards and accolades, we are the company which has the award for the most innovative technology for our flagship product Vivo ESAR. We also have the ET Healthcare Award for the same technology, and recently we have received the Commercify and CNBC Award for Translumina Therapeutics as the most trusted brand in healthcare. Being said so, I will just like to introduce the session today with our moderator and presenter, Dr. Sarita Rao. A name in the women cardiology, definitely. She's the senior interventional cardiologist at Apollo Hospital Indore. She's the first female interventional cardiologist in central India. So, when I'm reading her profile, I can see so many firsts here. She has numerous publications in national and international journals. She has received 7 gold medals during her academic career. More than 5,000 people have been trained, with her. And she's also been received the award for Bharat Kashyap for overall excellence. So she has done her first TAVI in central India. She is the women cardiologist who has done the first IVL procedure in Madhya Pradesh. So, with that, so many first, ma'am, Sarita, I would like you to take over the event and, introduce our chairperson for today, Dr. Jyotsana.
Good evening. Pankuri, can you hear me?
Yes, ma'am, you're audible.
So a very warm evening to everybody on this meeting today. And I welcome all of you to Shock Talk. And Dr. Jyotsana Maduri is our chairperson for today. She actually needs no introduction. She's very well known. She's head of the department at NIMS Hospital, Hyderabad, a very reputed interventional cardiologist. And what I would like to say is, Pankuri, Madam has actually paved the way for a lot of women cardiologists like us today. She is also the president of the WinCars Association, which is an organization of women intervention cardiologists and allied sciences. And she has numerous publications, numerous papers, and numerous accolades to her name. Should I take it further from here, Pankuri?
Yes, ma'am, please.
So today we have a very distinguished presenters and an expert panel. So we will have presentations by Dr. Haritha, Dr. Rupali Khanna, Dr. Zakia, and Dr. Preeti. And I will be doing a live inbox case. And we have an amazing expert panel of intervention cardiologists, which would include Dr. Parijat Dev Chaudhary, Dr. Shalini Garg, Dr. Richa Sharma, Dr. Ritu Bhatia, Dr. Sarita Gulati, Dr. Tabassum Khan, Dr. Sujata, Dr. Anupam Goyal, Dr. Mamtesh Gupta, Dr. Minakshi, Dr. Mashadi, Dr. Rashmi Xavier, Dr. Gautami, Dr. K. Dipti, and Dr. Ritu Bhatia. We would also like to take this occasion to invite our international faculty and chairperson, Dr. Anja Oksnes from Auckland University Hospital, Bergen, Norway.
Hi, thank you so much. Thank you so much for letting me come here and join this amazing meeting today. And congratulations to all of you strong women in cardiology on our National Women's Day. So I'm very happy to be here.
Thank you so much. And that actually brings us to the point that this Women's Day, we are talking about Break the Barrier. And to see so many women intervention cardiologists on one platform here today actually means that we are succeeding somewhat, because we are breaking the barriers with so many women cardiologists doing so well. Pankuri, which presentation would you like to take in first?
I think I'm supposed to.
Starting with Dr. Anja's presentation.
Yes. So Dr. Anja, we would.
I'll see if I can share my screen. Let's see. I have to. Okay. So now you can all see my screen?
Yes, we can see your screen.
Okay, good. So I'm looking forward to a nice hour here with you. So my name is Anja Øksnes. I am an interventional cardiologist in Bergen, Norway, with my main interest being CTO, PCI, high-risk PCI, and TAVR. And I will go through the CAD pool data from the Disrupt trials. So we know that PCI of heavily calcified lesions is associated with procedural complications and late adverse events. It impedes stent deliverability and it leads to stent underexpansion. So we have data showing us that there's an increased risk of MACE at 1 year with the moderate to severe calcium, and we know that the greater the arc length and thickness of the calcium, the greater the likelihood of stent underexpansion. So there are multiple devices for calcium modification, with IVL being the latest addition to the technology, providing a safe and efficient tool for fracturing both superficial and deep calcium. So the IVL catheter is delivered into the calcific plaque. The balloon expanded to 4 atmosphere, and acoustic pressure waves generates an effective pressure at approximately 50 atmospheres, fracturing both superficial and deep calcium. So this animation just shows the sonic pressure waves of the IVL catheter inducing calcium fractures and thus increasing the vessel compliance, which is what we want to achieve. So there are now 4 studies published to assess efficacy and safety of the IVL, and the most recent and largest is the Disrupt 3 study. This was a prospective multicenter single-arm study with 47 global sites, including 384 patients. And the early study results showed an excellent safety profile with only a 0.5% angiographic complications and 92% freedom of MACE at 30 days. And also there is a very reassuring MACE rate at 1 year in the high-risk patient subgroup. So we're now going to look at the patient-level pooled analysis of the Disrupt CAD studies. So data from the 4 Disrupt studies have been pooled together to allow for OCT and gender subgroup analysis. And if we start with the OCT sub-study, there was 260 patients who had OCT core lab analysis performed. And these are the baseline clinical and lesion characteristics of the OCT subgroup. 77% male, a lot of diabetes. But I think the key point here is that there was a total calcium length of approximately 43 millimeters. 34 cases had a IVL balloon dilatation, and 96% had dilatation post-stenting. If we look at the final angiographic and 30-day clinical outcome, There was no angiographic complications, and there was an overall 30 days MACE and target lesion failure rate of no more than 4.6%. If we look at the outcomes of IVL on eccentric and concentric calcium, these graphs show that no matter what the calcium arc, the MSA with IVL was above 6 millimeters square with a near 100% stent expansion. So these images just illustrate the impact of IVL in eccentric calcium. And here we see images with a calcium arc less than 180 degrees, and you can appreciate the calcium fractures post-IVL and with a good MSA. This is the impact of IVL in circular calcium, where we're thought in the start, right, that this was the best way to use IVL, and we can see calcium fractures in an excellent post-stent lumen area. So in these pooled data, they also found that the larger the arc of calcium, the more likely we were to see visible fractures, and also a higher number of fractures were seen per lesion. So having the calcium arc on the bottom line here, and you can see the visible calcium fractures on the left and the amount of fractures per lesion on the right. So regardless of whether there was visible fractures or not, the MSA and stent expansion were actually found to be the same. So why is that? It has resulted in a hypothesis that this is due to microfractures that we cannot see on the OCT, but we can see it on micro CT. So looking at these images, you can appreciate some fine microfractures showed on the micro CT that maybe isn't visual in our day-to-day intravascular imaging. So in conclusion, MSA and stent expansion is consistent in eccentric and concentric calcium, and MSA and stent expansion is consistent regardless of visible calcium fractures. Micro-CT imaging suggesting IVL induces calcium fractures not visible on OCT. So how about calcified nodules? So looking at this effectiveness of IVL in the presence of calcified nodules, from the pooled disrupt OCT data, they found that calcific nodules were more common in the RCA, somewhat also in the circ. A calcific nodule was identified in 22% of the lesion, and in 60% of these, there was also a calcium angle of more than 270 degrees. Looking at the post-stent outcomes, regardless of the presence of a calcific nodule, there was no difference in MLA and stent expansion post-IVL. Also finding that all eruptive nodules and 2/3 of all nodular calcifications were modified by IVL and stenting. So if we look at the post-stent outcomes, there was a greater number of visible fractures in calcific nodulus lesions with a concentric stent expansion in most cases. Also more visible fractures. So the formation of calcified nodules was observed on OCT following treatment with IVL. There was consistent MSA and stent expansion regardless of the presence of a calcified nodule, and increased visible calcium fractures observed in calcific nodules likely due to increased calcium concentricity. So IVL shock waves may affect deep calcium fractures, allowing for concentric stent expansion. I'll now present to you a case that I had a while ago. So this was an 83-year-old male. He had stable angina, deferred for CABG by the heart team, ventricular function of 40%. So this case was done rate radial action with a 7 French EBU 3.75. So the angiogram shows us subtotal distal left main, ostial LAD and circ disease with train tract calcium, indicating severe calcium with the necessity of some form of calcium modification.
Sorry to interrupt you. Ma'am, I can't see your slides.
You cannot see my slides?
Yeah.
Yeah, but we can. I think there could be some problem in your.
So Dr. Gulati,
Yeah,
I
we
think
can
since you
see
have
the slides.
yes. So Dr. Gulati, since you have joined from your phone, so that could be one of the reasons.
Really? Okay. How it's not possible? Previously, you were depicting slides. One speaker was showing. They were visible.
I think Dr. Gulati, it's visible to, I think, everybody else. Could you just rejoin once and see if it's visible?
Okay. Okay.
Do you want me to wait or continue?
No, please
Please-
continue.
Please continue, Dr. Anja.
Continue.
Okay. So here, wiring both branches, I was pre-dilating with a 2O-NC and then performing OCT I'm sorry, it's going to show the OCT. And performing an OCT in both the LAD and the circ. And here, the OCT of the circ showing a tight lesion with eccentric and nodular calcification. This is the, you see the concentric calcium in the LAD also extending beyond the angiographic tight lesion, whereas often where we see the most concentric calcium. So after this OCT, I decided to do IVL in both left main ALAD and left main circ, and you can here see the good expansion of the IVL balloon and the shock topics. I had to deliver all 80 pulses, especially the ostial LAD was tight. After the IVL, we see an excellent angiographic post-IVL result. So these are, on OCT, we see visible calcium fractures on the eccentric calcium of the circ and of the concentric calcium of the LAD. After this, the decision was to do left main LAD clot stenting. Here, the stent of the circ, and you can see an excellent stent expansion after the IVL balloon. This is a 4.0 20 megatron stent. And now rewiring the LAD and opening the struts into the left, into the LAD, performing pot and delivering a 3.5 32 megatron, which we also see expands quite nicely. Repot, rewiring of the circ, and doing a kissing, repot, and then an excellent final result. So let's see if this will run. So after stenting the LAD, there's a good concentric stent expansion throughout the vessel and the concentric calcium. There is a short segment with some eccentric expansion in the ostial LAD, but there's an excellent MSA. We often see this. I did post-dilate with a 3.5 OPN balloon at 24 atmospheres and did a final pot with a 5.0 balloon, but I was very satisfied with this result, and the patient was stable throughout the procedure. Okay, now back to the sex-specific outcomes of the pool data with the IVL. So they did a pooled analysis, gender sub-study with 144 women and 444 men. And we know that female gender is an independent predictor of adverse events after PCI for calcific disease, and specifically associated with complications following rotational atherectomy. These are the UK data for the ROTA study presented in CCI in 2020. The angiographic characteristics in the CUD study showed a smaller vessel diameter in women. That was the only significant difference. There was some less bifurcation lesions, but a heavy severe calcification throughout the characteristics. They found a shorter procedure time, fewer IVL catheters and pulses used, and less radial access. Regarding the primary endpoint, there was no significant difference between 30-day MACE or procedural success between men and women. And there was a very low complication rates in both gender. So from the data, we see there's no difference in the hospital and 30 days MACE rate between male and female. So in conclusion, safety and efficacy was excellent at 30 days in both women and men following IVL treatment. This in contrast to prior reports of increased risk of peri-procedural complications and adverse clinical outcomes in women undergoing PCI. I'm going to show to you just a short case. This is a CTO shockwave case, 80-year-old male, stable angina, and the decision was made to treat all his vessel, full revasc by PCI, right radial and right femoral access. So you can see this is a CTO of the right. It's heavily calcified and tortuous lesion. I managed to cross this with a Pilot 200 and a Corsair. And after this predilatation with a 2.5 NC before IVUS. I use IVUS mostly for intravascular imaging in my CTOs. And here you see a massive calcium burden throughout the vessel with thick and thin calcium, both concentric and eccentric. Thinking of which calcium modification device to use, I think rotablation here wouldn't reach the edges of the calcium at some portions. So I found IVL to be the best solution. So I think IVL will give us the best improvement in improvement of artery compliance. So this is the 4.0 IVL balloon, and you can see that it expands. Excellent effect of the balloon, where it cracks the calcium. And after 4.0 and 4.5 stent and a final 5.0 NC, you can see this excellent result of this vessel. So in our paper, we treated 55 patients with IVL in CTOs, both extra and intraplaque. And in the case of CTO PCI, we had a situation of pseudonodulus when working extra plaque. And I think these is one of the situations where we need more data to see the effect of IVL in this situation. And this graph just show that we use IVL in combinations with other devices, and the safety profile was very good. Okay, so that was my presentation for today. So thank you so much, and I look forward to seeing the other presentations and further discussions.
Thank you, Dr. Anja, for an excellent presentation and some excellent shockwave cases. I think your cases were very important and brought out some very important points, especially when we use IVL in distal left main bifurcation lesions. Where earlier, when we used to go with rota, we were not able to have a wire in both the vessels. And now when we are using the IVL, it's much safer for our patients because we have a wire in both the vessels. And in the event of any acute vessel closure, we are better equipped to deal with the situation. So I find IVL very helpful in the left main cases, distal left main bifurcations. Also, you brought out a very important point, because earlier we used to struggle a lot with calcific nodules when we were using rota because of the wire bias. It didn't really help us in the calcific nodules. And now increasingly when we are using rota, when we are using IVL in these calcific nodules, we are seeing giveaway, and we are seeing that we are being able to tackle it with that, because most of our centers do not have laser. So IVL has been very helpful in those patients also. So the cases were very interesting and elucidated very important points. Thank you, Dr. Anja. Over to Dr. Jyotsna for some comments.
You demonstrated the efficiency of the IVL in the case of the calcific lesions. Previously, it was too tedious to do the rotablation. At least the two people are requiring to hold the rota, even though there are the techniques of the folding of the rota wire and then doing the rota ablation by the single operator. But now this IVL is made so simple that in any complex lesions can be done. But the only thing we have to make sure that the effective luminal size is gained to use an IVL. And another important thing is, even though it is both sides, both L6 and LED has a calcium in this case, as doctor presented just now, but we can use the same IVL without using the balloons, because most of these proximal LEDs and L6 are the same size. So the size difference or also it doesn't happen. So a single balloon usage can be used in this. And it is an excellent case demonstration of the IVL.
Thank you, Dr. Jyotsna. I would like to invite a few comments from the panelists.
So what I think is important to point out is the use of imaging, because obviously to size the balloon, so you know that you get in touch with the wall, but also to see what kind of calcific modulating tool we are supposed to use. And I think as I've started to use imaging in almost all my cases, that really helps. And making a quick decision, I think also makes the procedure quicker. So I don't think it's going to take us any longer not to use it. I think it makes our procedures quick and efficient with a good result.
I fully agree with you, Dr. Anja. Imaging really adds value to the procedure and helps us to get a much better estimation of exactly what size we're going in, what size of balloon, what size of IVL, what size of the stent, where is the exact landing zone, whether we've actually managed to fracture the calcium, and what is the stent position. It really helps us in our procedures. So yes, you have also used imaging in your cases and elucidated it very well. Thank you so much. Quick comments from some of the panelists. Dr. Gulati, yes, please.
Can I make one comment, please? Just wanted to ask our esteemed speaker that how many cases she has combined rota and IVL. What is the percentage in her practice?
I've used it quite a lot. You know, sometimes when the lesions are so tight, you can hardly cross with a wire, needing a microcatheter, and you can just deliver the rota wire. It will be hard to deliver the IVL. So I think I've probably used combination therapies in, I don't know, 15, 20 at least cases. In our CTO population, we had 3 perforations with the combination therapy, 2 with rota and 1 where there was a cutting balloon, but 2 of these were like subintimal combination therapy, which is obviously something we don't know too much about. But I think we should be extra cautious when we do combination therapies, but sometimes, you know, a good result is also important, but yeah.
Yeah. How many times you found that IVL was not doing your job and you had to switch to rota? In how many instances you found that IVL was not enough and you had to switch to rota?
Yeah, I think that's very rarely. I think I've done that like in a couple osteo LIDs where I've had to do that. Yes. But that would just be to kind of shave off a nodule or something. But because it's all about the diameter, right? We don't have the rota burr, the biggest size. So I think usually when you have a failed IVL, that is because the calcium is so thick, and sometimes you end up with a suboptimal result. But in most of those cases, rota won't add anything to the case.
Thank you.
Dr. Anja, the IVL is used even for the side branch of the CTO to modify the plot of the CTO. Have you had an experience of it? Is that really going to be helpful?
I'm not sure if I got that. If to use a to use the IVL balloon in a side branch in a CTO? Like you mean proximal to the proximal cap?
Yeah, correct. Yes.
So yeah, there was a case presented now at CTO New York where they couldn't puncture the proximal cap, so they tried to deliver the IVL balloon into a side branch just at the proximal cap to see if it could induce some fractures. And in that, but that was like a single case presentation where they ended up modifying the cap in so that they could puncture with a penetration wire. I haven't used it. I've used it for retrocart to do reentry in a very healthy calcified vessel, and just for any kind of calcium modification in throughout the CTO where you to crack the calcium, and also subintimal rotablation is possible in shorter segments, but we feel a little bit reluctant to do that. Not sure if that answered your question.
I have a question. Do you always do imaging, and don't you use, because in our country where finance is an issue, we're seeing a lot of cases where they are doing without imaging also. So do you agree with that, or do you do all your cases with imaging only?
I do all my I'm not going to say that I do all my PCIs with imaging, but I would do all my proximal LED, left main, circ, all my CTOs with imaging. And I think, the calcium modification devices are so expensive. So if you end up doing rota and you don't get a good result, then you need to take like a cutting balloon or a scoring balloon or IVL. So the moment you pick up 2 modification devices, you would have spent more money than using the IVL. And also I find it to be very quick. So if you can deliver the imaging, like OCT is expensive, but IVUS I don't think is so expensive. So I think also it makes your decision making quicker, and maybe you'll end up doing more and more patients that day, saving the money in that way. So I don't think imaging actually brings up the cost with my procedures that much, because I'll avoid using 2 modification tools, picking the right one.
So actually, Dr. Anja, what Dr. Sujata is trying to say that 70% of the centers in India are not equipped with imaging.
Okay.
So that is what makes the situation a little difficult in India. So 70% of the operators in India still do shockwave therapy without being assisted with imaging because it's just not available.
Yeah. No, I don't think it's dangerous to use IVL without imaging, because you would do your procedure without it anyway. And if you wonder if you should use it, if the lesions is so tight, if you have like just some eccentric or concentric calcium, to use a balloon, do an NC balloon, try to size it 1-on-1 on the vessel and see if you can crack the calcium that way. You will know if you need something else. But obviously the cost of IVL is a lot more than the imaging. So yeah.
Dr. Sarita, if we have some time, one question from my side.
Sure, Dr. Harita, please go ahead. Last question in this session.
This left main interventions, like we have to deliver the pulses over 60 seconds, like it will take some time. We have to open the balloon for a quite lot of time. So if we occlude the left main for a significant time, will there be any problem that we face?
Usually, Dr. Harita, I'll just say a quick point before Dr. Anja takes this. Usually, most of our left main interventions, they tolerate this. These are chronic calcified lesions. They usually tolerate the IVL balloon very well. In the event that you see any kind of a hemodynamic compromise occurring and you feel that you should go down with it, so operators have tried giving 5 pulses instead of 10 at one time. That's also been tried. But usually, since these are chronic calcified lesions, they tolerate it very well. Dr. Anja, over to you.
Yeah, I very rarely, I've done left main IVL on critical aortic stenosis patients prior to TAVR. So if I see that they have some hemodynamic influence, I'll just let them rest between the pulses. Just take your time and let them rest between the pulses, and I think it's fine. I don't usually take it out again because sometimes it's harder to deliver. The IVL is actually surprisingly easy to deliver, but I try to keep it in place. So I was sure that I'll get to deliver all the pulses if I need it.
So thank you, Dr. Anja, for that very interesting session and a very good interactive discussion which we had among all of us. And we would now move to our next case. The next case is being presented by me. It's a live in the box presentation. So I will be presenting a stony-hearted native IVL means native. This is a case which we did 3 days ago. Technical support, if I could ask you to play that. It's a slightly large file. This is the last thing, so you would have to go to the beginning of the presentation.
And today I'm going to show you a patient, a gentleman who's 69 years old. He underwent a bypass surgery way back in 2017. He's hypertensive. He was asymptomatic till now. 1 month ago, he started complaining of dyspnea on exertion and angina on exertion. He was investigated, his treadmill test was found to be positive, and he was subjected to an angiogram at another center, where it was found that his SVG grafts to the RCA and his graft to the ramus were shut down 100% occluded. It was also found that the graft to the OM was patent. However, the Lima graft to the LAD had an 80 to 90% stenosis at the anastomotic side. So yesterday we went ahead and we fixed the Lima graft, and today the plan is to go ahead and do the RCA using IVL therapy because the RCA is extremely calcified. So I'll just run you through the angiogram and what we did yesterday, and then we'll go ahead and do the RCA. Now this is the angiogram of the patient. He had a distal left main bifurcation disease. This was the reason why he underwent the bypass in the first place. This is the LAD, which was 100% occluded. The RCA, diffusely disease, there's proximal 90% block, a mid disease of 80%, and again a distal disease of 90% just before the crux. Hugely calcified vessel, which is why we have intravascular lithotripsy on board. We're going to tackle that artery. And this is the Lima graft. You can see there was a tight block at the anastomotic side. And we tackled this yesterday. It was wired. Subsequently, ballooning was done. This is the ballooning being done of the anastomotic side, and subsequently it was stented. This is the stent in place. Deployed. Because of the concertina effect, we were not able to see a very good flow initially. We post-dilated the stent. Again, post-dilatation. And then you can see this was the final result. So the Lima has been tackled. Now we'll go ahead and tackle the right coronary artery.
So this was the right coronary artery. As you can see, there's a proximal heavily calcified lesion, a mid-calcified angulated lesion, and there is a distal 90% lesion too. So we wired it with a run-through wire, and we took in a 2 into 10 millimeter non-compliant balloon. Post-dilatation, this is what we had. Then we were not getting enough backup, so we had to change the guide to an AL1. Subsequently, we were able to get to the distal lesion and dilate it. Then we dilated the mid-segment lesion of the RCA. And then finally, we finished it off with a proximal dilatation. Now at that time, the balloon ruptured and there was a dissection at the proximal segment. So there's an aorto-ostial dissection now on hand, and we had to change our strategy at this point. So we decided that we will now give shockwave therapy. This is a 2.5 into 12 IVL balloon. The strategy was now to dilate the proximal lesion and stent the aorto-ostial dissection. So 3 pulses of shockwave therapy were delivered over there. Subsequently, we've taken in the stent. This is a 3 into 18 onyx. And it was implanted. Ostium was dilated, and then subsequently we said now we'll deal with the distal 2 lesions. Again, there was great difficulty in making anything enter into the RCA. Heavily calcified RCA, even with the extra backup guide that we had. And now we also had a stent in the proximal segment. So we had to take a support of a telescope, guide extension catheter, and then we are able to finally take the balloon inside and dilate the distal lesion. Then the mid-segment lesion. Mid-segment lesion was not opening up, so we had to again use the IVL therapy. This is the IVL balloon again. The rest of the pulses were used in the mid-segment lesion. Then we decided to stent the mid-segment of the RCA. This is a 2.5 into 34 stent. Then we went ahead and tackled the distal RCA lesion. Again, after repeated balloonings, we were finally able to get a stent into the distal RCA. So 2.25 into 15, and this was deployed. So this was the result. We went ahead with post-dilatation. Successful post-dilatation of all the stents were done. The ostium was flared. Now after this, we noticed that the ostium didn't really look very good at this point. So we took multiple shoots and we noticed that there was some slight staining there. We redilated the ostium thinking that there might have been some deformation of the struts at that point. And after that we noticed that there is some cuspal staining. So we knew we had a problem at hand. So immediately we took in another stent. This was a 4 into 9 millimeter stent, and sealed the ostial segment. checking for the final position and then deployment. So this was the final result. Now basically what happened at the proximal segment was the question, because we were very sure that we had covered the ostium in the first instance. We had hung it well into the aorta and covered it. What has happened is that because of the repeated use of the guide extension catheter and because of the repeated hitting of the ostial stent with the guide catheter, there was deformation of the proximal stent, and when we tried to correct that, there was longitudinal foreshortening of the stent. And this is why the ostium looked as it did, and which is why we had to use another stent to seal the ostium. So this case was interesting because of multiple reasons. We started out with a different approach and we ended up with a different approach. So normally we always stent our distal lesion first. In this case, we had an aorta-ostial dissection and we started off having to stent the proximal segment right in the beginning of the case. Also, because of frequent deep throating of the guide and because of difficulty in manipulating the hardware because it was a very calcified artery, we ended up having longitudinal shortening of the stent, the proximal stent, because of which we had to deploy another stent. But in the end, shockwave lithotripsy saved the day. The patient went home safe and sound. Ladies and gentlemen, thank you so much.
So thank you, technical support, for playing that for me. It was slightly difficult from my large video. So this case, I showed it because it was interesting, and at multiple steps we had to change our strategy and go in a reverse order. And then when you go in a reverse order, you sometimes run into unusual situations and then you have to deal with them. So I would like to have first comments from the house, and I would like to start with Dr. Anja and Dr. Jyotsna.
Yeah, this is a really challenging case, and you can see the massive calcium burden in this vessel. And that happens sometimes, that you get that ostial dissection, which need to be treated. I think you showed perfectly how a guide extension can facilitate the treatment of calcium distally in the vessel, and also it's a very excellent way to deliver your stent without hurting it, delivering it in calcium. As we could see in the CAD data, often there's this calcific nodule in the proximal right, which looked like it had been beautifully modified by the IVL, good stent expansion. I think maybe this case would have been a nice combination therapy case as well. You know, a rota burr, but you would have to have a small burr though to go all the way down that vessel to treat both the distal, mid, and proximal lesion. And the proximal lesion probably wouldn't be enough treated by rota, so you'd have to go with IVL afterwards. So no, I think it was a good result, excellent result in a really calcified vessel.
Thank you, Dr. Anja. And that was exactly my thought, that it was such a calcified vessel that I had wanted to use rota in this case also. But when I looked at the proximal segment, there was this, huge chunk of calcium which looked like a nodule. And I had the option. So in India, what happens is that the patient pays for the therapy. So I did not have the option of using both. I could only choose one to use. And I thought that with IVL, I would be able to tackle all the three. With rota, I might have failed at the proximal segment because there was a very huge chunk of calcium over there which might not have been modified. Thank you so much for your wonderful comments. Dr. Jyotsna, some comments from you.
An excellently done case. Really is a heroic way of the management of this calcific lesion. I will appreciate Dr. Sarita for this excellent case. And the few points what I wanted to add it is very much appropriate when there is an osteoproximal dissection. It is mandatory that we have to study that before going in. But I would have been done that, kept the telescope continuously, nor the guide into the stent to do the next of the procedure. So not that whenever the support is required, so that definitely then it is well known fact that the stent which is projected beyond an ostium into the aorta is likely to be distorted. Not only the distorted, even the displacements or the even pushing of the stents is known to then occur with that. So at the time, the keeping the telescope directly into the stent and doing all the manipulations will be then advisable. Second one, even I think then IVL is a better option, not only for the presence of the calcific nodule, for the so distal lesion of the RCA to treat with the rota is not possible. The rota, even though all said and done, the distal lesion to go to do the rota, usually the perforation chances will be the much more to go to the almost up to the bifurcation. I think the IVL is a better option than the rota in this case. Excellently done.
Thank you, Dr. Jyotsna, for your wonderful comments, and I really appreciate them. Now, the practical problem I would like to tell, while doing this case, what happened is that the distal lesion, it was refusing to let even a small balloon enter. And I was not able to transmit enough torque to that point or pushability to that point, which is why, so I had the guide extension catheter in, but I was not being able to deliver a balloon over there. And so ultimately I had to push the guide catheter over the guide extension into the vessel to get that balloon over there. And that is where I think I ended up damaging the osteal stent. And Dr. Sujata, yes.
Yeah, really bold case, I would say. Then I would also agree with Dr. Anja that maybe rota would have helped in distally, and maybe it would have prevented an osteal dissection. I mean, we are wiser retrospectively, and rota does a different method, like it causes a volume reduction of the plaque, which might not be possible with the IVL. So the rota tripsy using the combination of rota and IVL definitely would have been better in ideal situation. And my question to you is 2.512 balloon. It was not a 1-to-1. So why you chose 2.512 and not a 312? That's my question.
Okay, so Dr. Sujata, initially when we started out with the case, so I had great difficulty in even taking in a 2x10 balloon. So a 2x10 balloon also went in with great difficulty and failed to dilate the lesion. So for me, thinking of going in with the vessel size was 3.5, but for me to go in with a 3.0 IVL balloon, I thought it would not enter. So that's why I went in with a 2.5 balloon, because the policy of IVL is that you must have, it's recommended that you have a 1:1 sizing. But the second important thing which they say in IVL is that you have to have contact with the vessel wall. And the point at which I needed to give the pulses, there was no way I could get a 3 IVL balloon in. And a 2.5 balloon achieved contact with the vessel wall, which is why I was able to deliver the pulses with the 2.5 and break the calcium, and then subsequently took a non-compliant balloon and opened it up further.
Yeah, I agree on that. The most important thing is for the balloon to get in touch with the entire vessel wall to get effect. And of course, go as high as you think you can deliver.
Yes, thank you so much.
So again, two things, Dr. Sarita. Again. Wonderfully done case. I mean, a lovely result. Two things which I felt similar to Dr. Sujata. 1:1. Yeah, I would have tried 3, and the profile difference between 2.5 and 3 might not be as much. Pankudi, your comments on that, or Dr. Anja can tell us the entry profile of 2.5 IVL balloon versus 3 balloon. That is my first question. Second, I felt, Dr. Sarita, in the mid segment, it's a large vessel. You used 2.5, the second stent in the mid portion. I felt I would have chosen probably 3 or 3.5. It's a huge vessel when you post-dilated, probably with the same size. So that was another thing. But as I said, we can comment on now. You got a wonderful result. This is awesome.
So what I normally did, so when we started out, with the vessel. Like I said, I had great difficulty in getting a 2O balloon inside. So which is why we started with a 2.5 IVL. Now the vessel progressively grew in size. And what I always do, if we know that the stents can be post-dilated to a much larger size. So when I take a 2.5, I post-dilated to 3. So we achieved a vessel diameter which was higher.
Right. And when we got the longitudinal shortening, was that a Boston? You said probably it was Onyx in the beginning, right?
It was an Onyx.
All Medtronic stents.
Yes.
Oh yeah, we're not very commonly to. I mean, LSD we don't see much with Onyx, don't we? I mean, we do see it with, of course, Promus and other stents of Boston, but even with Synergy, I have seen. But Onyx, yeah.
So I went back into the literature and checked it out, because whenever something unusual like this happens, it's always better to see what other operators went through this. And there are several case reports in literature about this longitudinal foreshortening of the stent. So I'll show it sometime. It's a very interesting phenomena which happens.
It absolutely.
I think that's, and always stenting the left main, when you deploy the stent, you always need to really, really expand the ostium of the stent, because like using here, you need a really supportive big guide. And if you hit the edges of the stent with that guide, I mean, any stent will deform it. Even the Megatron will be deformed. So it's just all the struggles of the procedure sometimes do. And the most important thing is you appreciate it so that you can do something about it. And I want to go back to say that in this case, like in all cases, and I know imaging difficult, but I think sizing of the stents and seeing the result of our calcium modification and IVUS catheter is good. And I actually have both. I have the Eagle Eye, kind of the cheaper version, and I got the Boston version. And I think just for the sizing and all that, the Eagle Eye is good. Not easy to deliver though, but yeah, it would maybe have helped.
Yes.
Thank you, Dr. Anja. And I was actually right from the beginning. I was just waiting for you to make this important point that had I had imaging on the shelf at that time, it would have made it so much more easier for me.
Yeah.
So I was just waiting for you to bring up this point. So
I
thank you.
actually believe that if we are, I mean, regardless of money and budgets and all that, obviously, I can't use anything that I want, even though I'm from Norway. But I think if we're gonna do good for our patient, we need optimal results, and we know that good stent expansion is what makes the optimal results. So rather go with a cheaper stent and do imaging.
Absolutely. And how all of us women on this panel, we would have loved to have a hands-free and have all the hardware and all the armamentarium that we want to give our patients the best quality results that we want. But unfortunately, constraints of finances, constraints of availability have always been the problem for intervention cardiologists world over.
Yeah.
So now in the interest, thank you everyone for all your wonderful comments. And so in the interest of time, we will move to our next presentation. That is by Dr. P.N.S. Sarita, and she's going to present image-guided calcified circumflex treated with IVL. Dr. Sarita, please share your screen.
Can you see the screen?
Yes, we can see your screen.
Okay. So a very good evening. I think my slides are, they're blinking on and off.
Yes, your slides have disappeared right now. We can see it now.
Yes. So Advance Happy International Women's Day. So mine is a very simple case, but I have learned some few things about the vessel wall and how to do the case. Probably we should ask Dr. Sarita Rao to present at the end of the session. Yours is the most complex case of the session. So this patient is a 66-year-old male patient, presented with unstable angina, rest angina. So he is a diabetic and hypertensive. He is an ex-smoker. So this is the ECG, which is normal. But as his angina is typical, we have went ahead with the angiogram. We can see here that there is an ostial RCA disease of around 70 to 80%. So it is a codominant RCA. So the circumflex, there is a bit of calcium in the circumflex with around 80% disease. So diagonal is, there is a diagonal disease of around 80%. So LAD is normal, around 50%. So these are the findings. So initially we went ahead and wired the LCX with a pilot wire, pre-dilated the lesion with 2.5 into 12, 2.5 into 12 at 12 atmospheres. The balloon went smoothly, there was no problem at all. But still, as I could see the calcium there, I went ahead with sequential pre-dilatation. I just thought I would do an OCT in this case because of the calcium burden in the vessel and to size the LCX. So as the patient is having a borderline creatinine values, we used contrast with the saline mix. So here we can see that there is significant dissection of the vessel. Even there is medial dissection at some of the places. And there is significant nodular calcium also that is seen. At the main lesion, there is significant dissection extending into the media.
Sarita, can you show that calcific nodule there?
Oh, madam. Here we can see it, madam. This is one of the calcific nodule, and there is diffuse calcium that is seen in the 3 quadrants, almost extending. It is a concentric calcium that is seen. So again, we went ahead and dilated with a 2.75 into 10 balloon up to 16 atmospheres. So we tried with a stent, but it didn't cross the lesion. So we didn't, the distal point we could not achieve. We could not come to the distal point. It has crossed majority of the lesion, but near the calcium, it is not extending into the distal end of the plaque. So we removed the stent. So now, initially before taking the case, I thought it is a simple case and very easy. But later when there is a stent is not negotiable, then I thought of modifying the plaque with cutting balloon or rota or IVL. Normally, most of the times I do a cutting balloon, but here in OCT, when I saw significant dissection and an ugly plaque, I didn't want to go for a cutting balloon. I thought we would modify the calcium only with the IVL. So this is a 3x12 IVL balloon. Initially, I was like, maybe we may not be comfortable with an IVL 3x12, but still, as the vessel size was 3 in OCT, we went ahead with 3x12 IVL balloon. We gave the pulses from distal to proximal. We could not see a significant yielding of the lesion even after doing the IVL. So we have kept another wire. So we passed, pardon, I think these slides are not moving. So this is the stent that is delivered post IVL. So we could reach the distal part of the plaque. So this is the healthy zone near the OM branch. So we deployed the stent there. There is some problem with the slide.
Just click on the screen. Just click on the screen and see.
That's what I am doing. I could not see the mouse. Okay. So we post-dilated the lesion. There is a satisfactory post-dilatation that is there. This is the final result. So as the creatinine levels are borderline, we didn't do post-stent OCT. So after 3 months, we were doing the RCA lesion also. At that time, we did the circumflex. So it was good. Thank you.
Thank you, Dr. Harita. That was a very nice case presentation by you. A very nice thought process also. Dr. Harita, just one question. When your stent was not crossing, you had almost got there. Why didn't you use a guide extension catheter?
Actually, I don't have a guide extension at that time in my shelf. So we were almost, we are handicapped. So I thought we have to go ahead with some other procedure to modify the plaque.
Yeah. Okay. And did you think of using OPNNC at that time?
No. No, because we could see on OCT that there is a significant plaque and already it is broken. But this calcium is not yielding to the balloon. We have used that high pressure balloon and already ruptured the entire media. So I thought if we go ahead with any other balloon, probably we would not modify the calcium plaque, but it may rupture the vessel.
Do you think putting another wire would have helped you?
Yeah, at the end, just before placing the stent, we went ahead with another wire also. Still, we couldn't negotiate the stent.
I think actually taking the IVL here was smart. You saw On your OCT, you had a concentric calcium of more than 270 degrees with no cracks. In that part of the vessel, there was no cracks. And even though you had managed to deliver your stent with a guide liner or 2 stents or something, you could have ended up with the stent not expanding fully, which would be a worse situation. So having the IVL on the shelf, you had a great result with that. So yeah, I think doing the IVL here was okay, was good. Did you size the vessel distally and proximally with your OCT? Because it looked, I didn't see, but it looked quite big. The vessel looked big.
Yes, it was a 3 mm vessel. So we deployed this 3 mm stent and post dilated with a 3 mm balloon.
Okay. Good.
So your end result was very nice, Dr. Harita. A very nice end result which we had over there. And some more comments from the panel, Dr. Jyotsna, Dr. Sujata.
I also agree with Dr. Anj that IVL was the best choice because it was a calcific nodule, very with no cracks.
Any more comments? Dr.
Yeah.
Zakia?
Dr. Tabassum, your ma'am, very well presented case, Dr. Harita, with limited, when you were not having an extension catheter with you. But the thing is that you were lucky enough to get through the IVL even without an extension catheter. So there was a lot of calcification around there, which was not allowing a stent to track in. So I think having an extension catheter even for IVL becomes necessary because most of the time we have seen that even IVL to track, we need an extension catheter. Without that, it becomes really difficult. Just one quick this thing, why you didn't think about rota, ma'am?
Rota, actually, I thought because this stent only a short segment concentric plaque is there with the calcific nodule, I thought it would be simpler with IVL because patient is affordable and easy thing, and it is an unstable angina, rest angina patient. I don't know whether there is any thrombus in the, but on OCT there is nothing. But still, I thought it is wiser to go ahead with IVL.
Okay. And also, I think the calcification was a little deeper. It was medial more than intimal calcification. Plus, you had a nodule, it seems. So,
yes,
that could be one reason. Anyways, very well done, ma'am. The case was done very well. Well managed. Thank you.
Thank you.
I think the choice of IVL in this case was very good because she had imaged it and she knew exactly what she was dealing with.
Yes.
So there again, it helps us.
Dr. Harita, just one comment. Of course, you used OCT with 50-50 diluted contrast. Did you think of IVUS since the creat was borderline and I mean, just a thought. I mean,
we had an OCT here in our lab, but we don't have a IVUS.
All the practical issues. Fine.
There are people who are doing saline OCT also.
But Zakia, yes, absolutely. Yeah. But my own experience with saline injection, the images are not better than IVUS, frankly. I mean, if you have to use 100% contrast, yes, it gives you a better resolution than HD IVUS. Otherwise,
because you have already used opened an OCT catheter, it would have been nice to have a saline image just to see the opposition of the stent. We are only interested in that in this patient in the post image, So
that's an interesting thought. We could have taken an OCT run with a saline injection because we already had it on table. That's an interesting thought, Dr. Zakia.
Can I comment one thing regarding this contrast thing?
Hi, Dr. Rupali. Yes, please go ahead.
Yeah, actually the basic concern with OCT is your contrast. Like we all have this issue that, okay, we have to flush contrast, and any additional 4-5 runs of OCT, you give additional 50 to 60 ml of dye. That is like usually which we see in the bed. In our institute, I would say for past, I think so 1.5 years, we are using colloidal solutions. Now these colloidal solutions, what they are basically having the same viscosity, same as contrast. And these are usually available with your tetraspan thing. These are hydroxyethyl starches and they are pretty renal safe. and they give you better image quality as compared to saline, because with saline, the only issue is the image quality. If you use saline in RC, it gives a very good quality. But if you're using with LED and LCX, it becomes very difficult to get a clear image from that. So, but if you use these colloidal solutions, they are less nephrotoxic and they give a very pretty good images. So I think this concept of contrast and diluting with saline, it's I think we have to change it, and we can see a good image quality with these solutions also.
What do you use, Dextran?
Instead of Dextran, we have hydroxyethyl starch, that is a tetraspan. That is also colloidal solution, which is given to these patients. So they have a very good viscosity. So they give a very good clearance about as compared to saline. Because with saline, we definitely get suffered. You then don't get good image quality in LED and LCX because they usually don't give a very good blood clear images. With RC, it's good enough. Saline and RC is good enough.
Rupali, did you see any allergic reactions?
No, we didn't see any allergic because this was earlier with Dextran, which was like your high molecular weight Dextrans. That was allergic reaction used to be there. But these new one are relatively safer, and we have done about more than 80 cases. We have never seen any allergic reactions in there.
Ma'am, sorry to interfere. Any vasospasm have you seen with this?
No, we have not.
Okay.
So that is the advantage of us discussing in an open forum, and all the things which different operators use can be tried by all of us. So that's a very interesting thing, Dr. Rupali. We can all try using that.
How frequently you use this colloidal solution?
In all my cases.
All your cases?
Yeah.
Really good.
Good. Dr. Anja, do you have any experience with this?
Even if there is no renal problem?
See, it's usually we use imaging as a complex cases. You have to give contrast. So that's why just to
limiting your
just cut down on the contrast only.
Yeah.
Okay. Great point. Thank you so much.
Dr. Anja, do you have any experience with using this in your imaging, the colloidal solution?
No, I don't. I'll if with the poor kidney function, I'll use IVUS for that.
Okay.
Yes. So I wouldn't choose OCT for that since I have the possibility of both. I mean, the high resolution IVUS gives very good imaging. You can look at the thickness and everything. You don't always see, you know, if you have like a SCAD or something, you want to see what's going on. OCT is better, but usually you can get away with IVUS. So, but it sounds very interesting. So I would like to have that fluid combination. Maybe we can have that, have a notice from you to look into that.
Sure.
So thank you so much, Dr. Harita, for that wonderful presentation. We will now move on to our next presentation by Dr. Rupali Khanna, who's going to talk about complex made simpler using IVL. Dr. Rupali, please share your screen. Yes, we can see your screen. Could you go to slideshow? Perfect.
Okay. Good evening, everyone. A very nice sessions we are going into, and very good talks before what I'm going to present. So my cases, like basically what all have been presented, it will just re-emphasize that, okay, how this IVL can be helpful to us. So the only issue with calcified lesions is that why we are so much worried about it. So if we see, the only calcium is that we all know that if the calcium is there and we do not tackle it properly, we will going to have your increased likelihood of stent under expansion. We will have increased risk of complications. There will be longer procedures. That means we will not be able to deliver our stent. If you do not tackle this calcium properly, there will be stent malposition, and sometimes more stents would be needed. So if we are not able to assess the calcium, we are going to face all these problems in our labs. So as already we have discussed, that imaging becomes an important domain in these patients if we are able to do imaging in these cases. So how these different calcium can decides your different strategies can be done. We have seen nodular calcium, we have seen superficial calciums, we can have deep calciums. Now, how these different calciums can define your different strategies. So we all know that by imaging, we can easily see these patients that, okay, what is the type of the calcium? no debate whether to go for IVUS or whether to go for OCT. It's all our operative preference. And if the patient is having a normal creatinine, as already said, that we can easily use an OCT, get a good clear images. And if it is not, then HD IVUS, what I have recently have an experience with HD IVUS, it also gives a very pretty good images with the calcium and with other plaque morphology also, which was not earlier with 40 megahertz IVUS catheters. So we want to see this calcium basically depending on these imaging. So this imaging, then how it helps in defining the strategies in our patients. We all know this OCT-based score is well aware to us. So higher the OCT-based scores, we have to do any additional modality to be done either in the form of rotablation, either form of the lithotripsy, or if there is a lesser score, you can go ahead with your cutting balloon, or a normal scoring balloon can also be helpful in these cases. So first case which I'm going to show is he's a 70-year-old gentleman. He's diabetic. He had an exertional angina for past 2 years, and he had ACS in February 2021. And he presented to us after 4-5 months of his rest pain. And at present, he was in class 3 angina. His ECG was showing right bundle branch block. And if we see his echo, the echo was only mildly dilated, but hearing epics was hypokinetic, and ejection fraction was about 35%. So we took this elderly patient to term of angiography and with possible revascularization. We took a right radial route with a 6-French sheet. So this was his basal coronary angiogram. If you can see, the left main was normal. The LED was having a proximal severe disease with a large chunk of calcium on the proximal part, and there was a critical stenosis in the proximal LED. If we can see the epicaudal view, it was also confirming these findings. It was a heavy calcium in the proximal part, and there was a critical stenosis in the proximal LED, along with LCX was also showing your severe disease. If you see his right coronary angio, it was again the same, having severe disease. It was only PDA was coming and few PLVs were there, and there was a proximal mild disease followed by a mid-severe disease in this patient. So now the issue was in this patient was that, okay, he's having a triple vessel disease with a proximal LAD with having a severe stenosis in the LAD part. So it was syntax score was calculated, it was 27, and he was having a heavy calcium. Now, going ahead with this case was basically the intravascular imaging should be done to stratify his calcium scoring and to use a modality accordingly. So we went ahead. If we can see the LED, there was definitely an eccentric LED lesion and a chunk of calcium as protruding inside the lumen, which was seen. So this was a very tight lesion, so we were not able to cross our OCT through this lesion. So we first dilated with a 2.5 into 12 mm balloon. It gives a little path for our OCT catheter. And when we did the OCT, this OCT was showing still there was some stenosis, and there was classical calcified nodule, which was present at 11 o'clock till 1 o'clock in this patient. Similarly, there was a calcified nodule at the point of your B point in the mid part. There was a critical stenosis, which was there from the 2 o'clock till 4 o'clock position. And again, there was a 180-degree calcium arc, which was present at the point A, which was about your thickness of about 8 to 9 millimeter. So now our strategy was that this has to be tackled now. Calcified nodule with a lumen area, either we can go for a rotablation or from a IVL cases. So this patient already had a eccentric lesion, so we were not very comfortable that how we were able to successfully the rotablation with a wire bias thing. So we took a IVL balloon of 3 millimeter because the distal LED was measuring about 3 millimeter in our case, and we gave about 8 pulses at 3 sites in our cases, at the distal part, mid, and the proximal part. Post IVL is again showed that, okay, the calcified nodule, there was some fissure which was seen in these cases, and there was good expansion of the lumen area. So we were comfortable that this was the post IVL picture. The lumen area was well formed, and we thought, okay, now the stent will be expanded in our case. So we took a 3 into 38 millimeter everolimus eluting stent and deployed from the proximal LED. Since the proximal LED was measuring 3.5 millimeter, we post dilated this NC with a 3.5 into 12 mm balloon, and we did a pre and post OCT in this case. Pre-NC and post-NC OCT was done in this case. So if this was a very expanded stent, which was giving a good TIMI3 flow. When we calculated the minimal stent area at the nodule part, we can clearly see the minimal stent area which came about was more than 6 millimeter. It was 7.06, and the proximal part was 7.7. So the whatever the cutoffs which is saying that it's having a good extent expansion, so we were sure that this patient will have a less chances of developing a stent malfunctioning in future. So the next arteries was simple to tackle. So this was LCX was tackled with your evolumus eluting stent. About 2.75 into 24 mm was deployed, which gave a good result. And RCA was then again easy to tackle. There was no calcium, and 2 overlapping stent of 3 into 28 and 3 into 24 millimeter stents were deployed. So if we see this final case, final angio, this patient started with your, sorry. So this is what we started with. Sorry, I don't know what happened. Yeah, so this what we started with, having a very ugly looking calcium, and this what we achieved with a good imaging color and your IVL used in this case. Second case he's a 70-year-old gentleman. He was hypertensive and he had a posterior wall MI on August 21. ECG showed a prominent R in V1 with having a normal LV function. We did his basal angiogram. There was LAD was free of significant disease, having OM severe disease, and RCA was proximal long severe disease, heavy calcium. So since he had a posterior wall MI, so first we tackled his LCX. This LCX was showing a critical stenosis, which was a thrombotic lesion, and we deployed a 3 into 24 mm stent, and this was giving a good TIMI3 flow in this case. For tackling the RCA, now RCA was, if you can see, having a heavy calcium in the proximal part, and we were not able to took a 2 mm balloon, but it was not responding to the dilatation. So we did an OCT in this case to see the what stopping us. So that was the thing which we found. The LAD RCA was having a heavy calcium arc measuring about more than 180 degree, and there was at least 20 degree arc here, which was having a depth of about 6 to 7 millimeter in this case. So since the diameter of the distal RCA was 3 mm, we took a 3 to 12 mm IVL balloon, and it took us at least 6 to 7 pulses to respond to this IVL, because if you can see, this was again not responded. This was a big calcium. Post IVL, we can show we were able to see a good fissures in these cases with at the level of your calcium arc. If you can see, this is a 270 degree arc. We got a good fissure in this case, and the IVL responded in this case. So then it became an easy to deploy a stent in this case. We deployed a 3 into 40 millimeter sirolimus eluting stent, and this was the final result which we got. I don't know what. I don't know, it's not running. So we got a good well-expanded stent in this case. So basically in calcium lesions, the issue is that we have a high calcium score. The imaging becomes a very crucial role in these cases. If you have a superficial calcium or a thick calcium, it will decide your strategy. If you have a big arc of calcium, or if you have a calcium nodule, then again your strategy becomes very difficult, because these patients will be difficult to deploy the stent or to expand it properly. And it's whether to document the fissure of these calcium to ensure proper expansion. Again, as already told, the CAT3 study, at least only 60% showed the fissure expansion. So just post IVL, whether to do OCT in all the cases, it's still, I'm not very sure. And the basic predictor of MACE is your minimal stent expansion should be seen in these cases, so which should be documented on your imaging. Rotablation, when should not be done, or when should the IVL should be preferred? Ideal scenario for rota is when you get a circumferential calcium with lumen size is less than the burr size, so you can easily touch the calcium with your burr in these cases. So whenever you have an eccentricity, your lumen area is very good, or you have a guide wire bias, then it becomes a little issue with doing for this rota ablation in these cases. So IVL can help us in your dealing with these cases, especially when you're having a nodule or a eccentricity calcium. So this is the algorithm which we all follow in our, which is commonly followed by everyone. If you've got deep calcium, you can go ahead with your cutting balloon or a scoring balloon. But if you get a superficial calcium with a thickness and a length and an arc is more, then lithotripsies are better. But if it's a balloon uncrossable lesion, then you have to go with the rota ablation in these cases. And the best is you have to stent should be seen whether it is a stent expansion is proper or not for treating the lesion in these cases. Thank you.
Thank you, Dr. Rupali. Very nice presentation by you. Very nicely elucidated two cases. Very scientifically done with a very good use of imaging. So I would now like to invite Dr. Jyotsna to give some comments.
Yeah, actually, it's a good result, and I think it's, even though it's a non-complicated case, but the performance was very good. Only one point I want to tell is the tight lesions of the lady. Rupali mentioned that at the beginning the OCT was not crossed, that's why we have not done it. But what I suggest is for the IVERS, if the tighter lesion is okay, but OCT, when the tighter lesion is there, you have to balloon dilate it, because you should have the distal flow to pull back to the OCT. So the tighter lesions, it is better not to do the OCT. You do the balloon dilatation, achieve some lumen, and then do the OCT. Otherwise, yes, excellently done case.
Agreement.
Dr. Zakia?
Yeah, very well done cases. But my only question is, should we be really documenting fracture of calcium every time? Or
that's what
I generally don't do it. So that's why because Anja just said that at times you can't see those cracks. In fact, those cracks could be so micro that your OCT also may not be able to pick up. So
I agree, ma'am.
So I was just wondering that,
Like in my last slide, I mentioned also whether to document these fissures is really necessary, like you are going for one extra run in these cases.
Yeah.
So I feel that if you're able to expand the balloon and you don't see any waste, so we should be comfortable to deploy a stent in these cases. I totally agree with you, ma'am, in this.
Yeah, I have a comment as well. So I think that was absolutely beautiful pictures that you showed. And I mean, I don't think we need to do 4 OCT runs in all patients to show everything. But so if you have you see the balloon expands, and sometimes you'll pre-dilate again with an NC balloon. So that's probably good enough. But also sometimes it's nice to see these fractures. Coming back to your algorithm, I think, like the slides that I showed and that I showed in the CAT3 pooled OCT data, is that we can use IVL probably both for nodulus and for the deep calcium, and that when you have a nodular, usually you have a greater concentric arc around it, and you will have the effect of the IVL maybe in more cases than we did learn in the beginning when we started using it. That was kind of the more limited patient population, but now I think we can use it in a wider population, and it looks very safe. So yeah, so I think this was a really, really nice case. Good.
I agree. Thank you.
I have a question, Dr. Anja. The thing is, most algorithms of calcium, as you said, in nodular calcium, they suggest rotablation rather than IVL. With growing data, you're telling us. But I have a question. Supposing there's no IVL, though most of our nodules, the arteries will be more than 2 millimeter. So with if your wire is showing that it is touching the nodule, can we do the rota?
Of course. I think and we've all done that, like in the ostral rights, where you have a huge chunk of nodule. If you take a big burr, you can shave off that nodule and you can induce cracks. So I absolutely think rota has a place in all kind of calcium. It's about just picking the best tool for each patient. Yeah.
I think, Dr. Sujata, before the advent of shockwave therapy, that is what we were doing. Yeah. But now with the added advantage of shockwave, we're adapting to it very nicely. It's made life easier and simpler for a lot of cardiologists. and especially for our newer ones who are not so handy with rota as yet, using shockwave has been a boon for all of them with the low, learning curve.
Absolutely.
Yes.
I'm waiting for the algorithm to change, First algorithm to rota for nodular calcium. So that, right.
I have to leave you guys very shortly because I have a plane back to Norway, but I have to ask you, so my hospital in Bergen, we have a friend hospital in India where I know some of my colleagues have been to work. So I'm just gonna read up the name of this hospital. It's the Christian Medical Hospital in Vellore.
Yes,
That's
a nice institute.
Yeah, so some of my colleagues have been down there to work. So thought that was an amazing experience. Okay, it was so nice to meet you all. And hopefully we'll see you again, maybe live at some conference somewhere. And good luck to all of you. And thank you for the great cases.
Thank you.
Thank you, Doctor.
We will invite you for the WCC if you can make a time. We will be very happy.
What did you say?
So Dr. Anja, Dr. Jyotsna is president of the WinCARS organization, which is holding its annual WCC conference, that is Women in Cardiac Care conference, from the 6th to the 10th. The 6th is the day that we have all our intervention cases and intervention presentations. We are being joined by a host of international faculty also, and from various centers across the world. So we will send you an invitation too, and it would be nice if you could log in for a while.
Sure. Sounds great. Okay. Goodbye.
Thank you. Thank you, Dr. Anja. And we will now move to our next presentation. Dr. Zakia Khan will be presenting managing complex calcified lesions with IVL. Dr. Zakia.
Yeah, thank you. Can you see my slides?
Yes, Dr. Zakia, we can. Please proceed.
We'll go to the full screen. Yeah. So this is a case, an elderly lady who's presented to us with
Dr.
stable
Zakia, you have to go
angina.
to
She was
slideshow.
70. Can't see?
You have to go to slideshow.
I think I'm already on slideshow. One sec.
Can
you see my presentation at least?
We can see your presentation.
Yeah.
But if you can go to play or slide, sure.
Yeah, I'll just see. Does one remove this thing? One second. So this was an elderly lady who presented with an unstable angina with a previous history of open heart surgery. So she had undergone ASD closure almost 28 years ago. When she presented to us, she had STT changes in inferolateral leads, and there was a hypokinesia in the inferior wall on presentation. So we did her angio, and you can see the angiogram. Very tight, long segment lesion in the RCA.
Actually, we can't, Zakia. I'm not sure others can, but I can't see your angio.
No?
Dr. Zakia, we can't see your angiogram. The slides are not moving.
I'll unshare, stop sharing and again share. Can you see now? One second.
We can see the presentation again. Still not in, Can you move the slide and see if it moves?
Stop sharing and then restart again, maybe.
Yeah, restart. Dr. Zakia, I think you're in a protected view. So just at the top of your screen, you will see it says enable editing. Just click that enable editing and then it'll go to play mode and it'll go move. Yes.
You can see?
We can see, but again, you're in, can you see that enable editing over there?
Where exactly? Can you just point it out to
above.
me?
It's just above here. Yeah, above there.
New share, pause share.
It's beneath the view, a little to the right. There's enable editing written there. Just click that. Yeah, and now go to slideshow.
Yeah, okay.
Go to slideshow now, it'll work.
Can't see my slideshow.
We can see it now.
Yeah, you can see?
Yeah.
Okay. Go to full screen. Can you see now?
We can see your slide. Try moving your slides.
Now you can see moving slides.
No, we can't see moving slides.
Sorry to interrupt. Ma'am, you can just have a new share in the top. Again, you can try a new share and select.
Yeah, do a new share. Now it's not in protected, so it should work. Try a new share.
Share.
Stop sharing and then share again.
New share and with the full screen.
New share.
New share, you will be able to see the PPT in the slideshow mode, the full screen.
Can you ask the last presenter to present in the meantime? Otherwise, I'll just try to fix this. I don't know. One sec, I'll try it once again.
Just try it once. Last time.
Share. New slideshow.
Go to slideshow.
Gone to something else. So Pankuri, you can do this.
Yes, ma'am. So I have just shared my email ID in the chat box. You can send me your slides and I'll share it on my screen.
Okay, so meanwhile, we'll move on to our next presenter. And we'd like to invite Dr. Preeti Sharma. She's going to be presenting ACS with calcified left main disease, rotatripsy with DKQ loss.
So good evening, everyone, and I'm really glad to be here and such a nice session. And I would like to present this case of acute coronary syndrome with calcified left main bifurcation disease. I did this case with the rota ablation along with shockwave lithotripsy, and we did DKQ lot in this patient. So this was a 67-year-old male who was hypertensive, ex-smoker, and a severe COPD. And he this time admitted to us with chest pain at rest for 2 hours, and ECG showed STT changes in leads V3 to V6. TOP was positive, echo showed RWMA and LADL6 territory, and ejection fraction was 45%. This patient was taken up for angiogram, and this was done through right radial route, which showed that severely calcified disease, mid-LAD calcific disease, tight lesion, and LCX osteoproximal, mid-circ disease, LAD disease from the proximal to mid-segment. So here we can see that it is ostial LCX and mid-LCX. This is the LEO caudal view. And this was the RC. This was the left dominant circulation. So this RC is actually giving collaterals to the distal LCX, which is a CTO. So for this patient, he was a 67-year-old gentleman in view of calcified LAD-LCX disease. We had first thought of sending him for CABG. It is Stent score for this patient was 26. Hearting meeting was done, but because of severe obstructive and restrictive pattern, he was declined for surgery in view of high surgical risk. And we were deciding for the technique for this patient, how to do this patient in view of severe calcified disease and ACS situation. And in between, patient had rest angina, 2 episodes in CCU, so he was planned for PTCA. What I anticipated in this patient was, because of calcification, we definitely needed a plaque modification with the rota or cutting NC. We were planning to decide it on the basis of imaging. We have OCT and IVUS both in our lab. And in view of dominant circ and LAD osteal disease, so practically a left main bifurcation, we were planning a 2-stent strategy for this patient. And most of the time we do our procedures in provisional through transradial, but for this patient with this much left main bifurcation, we planned this patient with a femoral root 7F sheath. And we debated for use of mechanical support. We have IABP in our lab, so it was kept on standby. So the first thing was to see his femorals. So right is okay, left is okay. And then we did procedure through right root, and we had a 5F sheet into the left femoral. And then we did, because now the plan was to do a simple balloon dilatation in the mid segment, and so that we could pass a OCT catheter. Because of calcification, we wanted to use OCT in this patient, but no balloon could cross the lesion. So we actually had to change it with the rota wire, and then we had to do rota ablation in this patient. So this was 1.5 BUR, and we did 4 or 5 passes. The mid segment was, you would see in this slide, that there was little difficulty in passing through the segment where the diagonal was. So it was actually, then it crossed, but in the meantime, patient started having chest pain, and we could see ECG changes, and his pressure dropped to 50. So immediately through left femoral, we had to put an IABP in this patient, and then we had to again, change the rota wire with the normal wire, and then we dilated the mid segment with a 2O balloon, and then we could cross the OCT catheter in this patient. So this is from distal to, so we can see that there is some deep calcium, and then yes, this is a better looking lumen, but here we approach, this is a calcified nodule, and above that you can see that there is a thrombus above. So because of thrombus, we actually had slow flow in this patient, and with rota, we know that in these kind of lesions, sometimes we can stuck with slow flow and no reflow. So we dilated the mid segment with a 2O, 2.5, but the upper, the proximal LAD lesion was not dilated. We could not dilate it with a 2.5. Then we actually had to do IVL in this patient, and we took a 3.5 12-millimeter balloon, and we gave pulses in the proximal LAD segment as well as in the LM. And when we could see that the balloon was expanding nice, we did a post dilatation we did a dilatation with the NC balloon 3.5 into the LAD, LM, and the proximal LCX. We did a cutting balloon, and then followed by that we did a NC balloon dilatation. Followed by that, we first implant a stent 328 into the mid LAD. And a 3.5 33 des into the LCX, and then 3.5 28 from LM to LCX. And then the port was done. And after crossing the wire, this first kissing balloon was done with a 3.5 12-millimeter balloon into the LAD and to the LM. And then
Stent was placed from LM to LED, overlapping with the previous stent, 3.528. What was done with a 4.5, 8 mm balloon. And then circ was recrossed, and again the kissing balloon dilatation was done. So this was the result we could get in this patient. So we did take imaging, but because of because the guide was not properly hooked, we could not get the good images post PTC in this patient. But we could see that the expansion of stent was really good in LAD and LCX. So my take-home message from this case is when we have ACS patients with LMCA disease, these are the most high-risk type of CAD patient. And we have to plan these patients, and the use of imaging IVOS and OCT, they actually help us to guide our procedures in presence of calcium, as well as in guiding procedures in terms of provisional or a two-stent strategy. And in ACS patients, always think of using mechanical support. If a patient is hemodynamically unstable, as our patient was having a good hemodynamics once we started the case, but in between our patient had slow flow, and because of that we had to use IBP in this patient. And I was lucky that I could get through, but rota ablation, whenever you are doing in ACS situation, it is preferable to see whether there is thrombus, and then in this kind of situation we should refrain from doing rota ablation, because with the slow flow and no reflow, sometimes we are actually stuck in these complex situation, arrhythmias, hypotension, and then sometimes saving a patient's life becomes very difficult in these kind of crucial situations. So be ready, be aware, and then use these tools judiciously in your patients. That is the take-home message from this case. Thank you.
Excellent presentation, Dr. Preeti. Thank you so much for that wonderful presentation. You demonstrated an excellent case of a combination of rotatripsy, which we sometimes need in a lab. But having said that, you know, in the initial circumstance, you were not able to cross the balloon. It was the rota which you did, which helped you to further use the other armamentarium which you required. So I think both of them have their own beautiful places, and both are required many times. You had a very good end result. Dr. Jyotsna, your comments? I think maybe Dr. Jyotsna is not there. Dr. Sujata?
It showed our favorite technique, rotatripsy. I think both work in different ways. One, rota causes volume reduction of the plaque, and this cracks the calcium. So you've shown it wonderfully in your case. Good job, Preeti.
Do you think before taking such cases, is it a good idea to maybe give them a day prior some GP2B inhibitors? And
no,
then will it reduce the complications of thrombus migration or anything?
Ma'am, you are never sure of, so there's no data to support this. And we have seen that if you do that, there are high risk of bleeding. Whenever you are using these 7-8 French guidings and these IABPs, and I mean, you are more into complications rather than a definite data to support the use of GPI before doing these complex PCIs. So I would rather load my patient with a dual antiplatelet. Maybe I will wait and then on table if I feel, because in this patient also, to bail out the situation, I had to give intracoronary epsiximab. So that is my favorite thing to reduce slow flow, no reflow. So just bolus epsiximab does wonders, and within minutes you see that the thrombus which was there and was causing no flow, and you have a good flow, and then you can actually maybe you are able to get a good TIMI3 flow in ACS situation and in situations like this with the IC epsiximab. So this is our protocol in our lab. Maybe others have different protocols in their lab, but it actually mostly many a times it helps us in these difficult situations.
Preeti, I agree.
Yeah. Carry on.
You know, we more often use it as bailout during the situation, 2B3A. So I agree with you. We don't load them upfront, but yes, during the procedure, whenever we run into this slow flow kind of a situation of vessel shutting down or thrombus appearing, and then we usually use 2B3A in a bailout situation. And many times post-procedure, we do carry them on, but upfront, we don't usually use it.
Yeah,
I agree with you. Dr. Ritu, you were saying something.
Yeah. Preeti, very nice result. 2-3 points which I would have probably taken into account, as you rightly said, ACS, thrombus, whether visible or not, whether you document or not, it is going to be there. So rota, we have to be really careful, one. Secondly, probably you did DK crush, right?
DK culotte.
Okay, so my personal experience with both of the culotte is a little quicker than DK crash, but I would say if given a choice, I would have probably gone in with the nano or mini crush, which is much faster, you know, and in bailout situations, they are the better, you know, you need not cross repeatedly. So that would have been a different thing. I would have probably, with so much of calcium and everything going on, I would have chosen IVUS over OCT. It definitely saves time. It does, the crossability is much quicker, and whatever you wanted to know, you would have known with IVUS also, you know, OCT, then injecting. It is definitely a longer thing. I mean, otherwise the end result was fabulous. I congratulate you on that. And Zakia, as Preeti said, I think GP2B3 inhibitor with the latest kind of antiplatelets, definitely. I prefer eptifibatide bolus, not intracoronary. 2 boluses or 1 bolus intravenous. The anesthetist takes care of that. It does help a lot. Now with Cangrelor, I'm not sure how many of us have used it. I think Cangrelor could be a fabulous choice in such cases where you really want to have like platelet inhibition in 1 or 2 minutes, and then you can probably switch them over to ticagrelor. So these were the comments from my side.
So thank you, ma'am, for your comments. And regarding calcium, if given a choice, I will always use OCT over IVUS in calcific lesions, because just to see the deep calcium, superficial calcium, just to see the calcific nodules, the extent you can see on the IVUS, but just to define the calcium, I mean, OCT is a better tool, which I have learned in my practice. And regarding rota, yes, I told you that our plan was to decide on imaging, but nothing was crossing. So we actually had to do rota in this patient. And the third thing,
exactly.
Preeti, atherectomy, you already knew from angiography also that you will require something for atherectomy, right? So frankly speaking, imaging, even if it was not there, you would have probably gone the same way. And when we compare OCT and IVUS, frankly, we have few cutoff points like this, like if rule of 5 and all that in OCT, but IVUS gives you a fair result. I mean, you can decide on IVUS also. And with HD IVUS, these are very, very good.
It gives you a reasonable information.
You can be choosy when it is not acute coronary syndrome. All points well taken if it is not ACS. But in ACS with a 50 pressure, I would not use OCT, frankly.
No, by the time, obviously not. If a patient is unstable, then we don't use imaging. Then you have to be quicker. You have to just do the case and come out. And just you can check your post-procedure result. But not at the pressure of 50. Once the patient is, after putting IVP, once the patient is stabilized and you have done the dilatation, now the hemodynamics is good, then obviously one can, it is operator's choice. If you think your patient is stable, you can do imaging. Definitely it is going to give you some information which might help you, as I knew that there was thrombus by doing OCT, and which was not actually visible on the angiogram. And obviously in unstable patient, there's nothing like imaging. You have to just bail out the situation, quickly stent this patient. You have to make procedure safe, and you have to move this patient safely out of cath lab. So that is the idea once you are dealing with these kind of critical situations. Definitely, I agree with your point.
So I think for all of us, Dr. Preeti, whenever we're in a crash situation, it's quick in and quick out with the patient. Yes. Get him out as fast as we can, stabilize him. So that's a very interesting discussion which we have. I can see Dr. Mashadi Mahapekar is also on the panel. Dr. Mashadi, would you like to add a quick few comments?
Hello, first of all, I would like to congratulate you for a wonderful case. And I agree with all the panelists that it is, if it is a crash kind of a situation, quick in and quick out is the best option. We need to really get in quickly and get out and salvage the patient. Imaging would only be an option when the patient is stable and we have all the armamentarium and the facilities to be generous with our procedure. The time is of utmost importance. If you have the pleasure of having a lot of time on your hands, yes, imaging is absolutely essential. Otherwise, quick in, quick out is the way to go. A good job.
Thank you, Dr. Mahapekar. Dr. Preeti, I would have loved to see a post-imaging run in your case.
I'll show you. I'll send it to you because it was not that good. We could get a good expansion of Stent. So that was, I was really worried of, because you know that post-procedure re-stenosis is really related to the area you are achieving. So you have to be really, I mean, you should put efforts to get a good result. Then only doing a left main is justified. That is only intention.
Otherwise, when you with stented left main, sometimes it is very difficult to get good OCT images. Actually, you can get better IVUS images, but it's very difficult to get a good engagement of your guide catheter and get a good injection and get a good picture with OCT. So it's always an issue. Always an issue with OCT. Yeah.
That is an issue, and that's when for left main I always prefer an IVUS for the left main. Dr. Sujata, you'll disagree, because when I did left main, I took the telescope and I did it. Yes.
You can do anything with anything. Okay.
So Dr. Sujata is referring to the live case I did on left main, and I had to use OCT. So I went ahead and used the telescope because the proximal portion of the telescope is infrared compatible, and you can actually image the left main with the telescope using OCT. But if you're not using the telescope, you have to go in with an IVUS. And Dr. Sujata is actually very fond of OCT.
Yeah, the pictures are actually very beautiful of OCT, you know.
Yes.
That's the difference between OCT and IVUS images. I think the pictures are beautiful.
Yeah, and it gives you a very good amount of information. But then for left main, again, I still say that I like IVUS in left main.
Right.
So we'll go to a final presentation with Dr. Zakia. Dr. Zakia, could you please share your screen?
Yeah, I think Pankudi is sharing. It's a protected view. I think Pankudi will share the things. Yeah. So can you go to the next slide? Yeah, so this patient, as I said, was a post-ASD closure patient, elderly patient, almost reaching 80 years, presented with unstable angina, inferolateral ischemia, and wall motion abnormality in inferior leads. Pankudi, can you go to the next slide, please? Can you play the video? So you can see the image. That's a very tight RCA stenosis, long segment lesion, calcified. Can you go to the next? There's another lesion in the LAD, proximal LAD. You can see heavily calcified lesion in the proximal LAD. So this was a double vessel disease patient. Since it was calcified, elderly, post-open heart surgery, I didn't do the case on the same case. We don't have the luxury of having all the things on board with us. So I said, we will image this patient, take a call depending on how bad is the calcium, whether to use a cutting balloon, whether to use an IVL. So we said, we'll keep everything on board and then do the case. Can you just go ahead with the pictures, please? Next, please, just show the videos. Yeah. So we went ahead and did first I had to actually dilate the lesion of the RCA. It was very tight. So to a balloon, I had to dilate it with C balloon, then put my OCT catheter. Next, please. Just show the OCT images. This is like completed case. Can you run the OCT image, please? Can you see that the OCT is showing significant calcium at the site of lesion, significant deep calcium? Yeah, here you can see very deep calcium, very tight lesion. And the artery was pretty big size. It was almost 4O artery. You know? So can you come back on the video for the RCA plasty? Come back, come back. So the lesion was dilated with a 4O IVL balloon. And then we used 4O stents, 2 overlapping stents in the RCA. Can you show the next image? Good picture. And the lesions were post-dilated with the 4O balloon. Next, please. Can see that good expansion. Can you show us the OCT image? Just go back here. Yeah, this is the OCT image post deployment of the stent. You can see that the stent has deployed pretty well, no edge dissection, good luminal area, and good stent apposition. So here we used about 50 pulses in the RCA. We had remaining 30 pulses. So then we went ahead and did the left coronary. So can you go ahead further? Next slide, please. Next slide, please. You can see the calcified LED lesion. No, it's a post-stented. Just show the OCT. Yeah, yeah. Now see the OCT of the LED. Although you could see a lot of calcium on the screen, but compared to the right, you see that the amount of calcium here is less. The artery was almost 3.8 millimeters. So we went ahead and used the same IVL balloon, 4O balloon, delivered 30 pulses over there, put a 3.5 stent over there, and then post-dilated with a 4O. Now you can see the OCT here. Very well opposed stent. No edge dissection. So Pankudi, can you come back and show us the stented images? Yeah. Play. So you can see very well opposed stent. No edge dissection. Next slide, please. So patient did, next please. Patient did quite well. Almost now more than 6 months post-procedure, she is doing pretty well. So this particular case I presented because we used one balloon in 2 arteries. And we were generally, when you plan elderly patients, post-operative patients, what you actually see on screen may not be enough calcium, but when you image them, the calcium is significant. That helps you to strategically decide which plaque modification to use. So I think in an elective case, it is always better to be prepared with all the armamentariums. Thank you. Thank you.
Thank you, Dr. Zakia. A very nicely presented case and a very good elucidation of the use of a single shockwave IVL catheter to tackle 2 calcified lesions successfully. A very good display with imaging of a very successful, well-expanded end result. Thank you, Dr. Zakia. Very nice case. So we will take expert comments from the panel. Dr. Sujata.
I think we've already discussed everything, and she showed what we discussed. Good expansion, good MSAs. So I think I have nothing to add.
Dr. Mashadi, would you like to say something?
Very neat and a very clean and a good case.
Thank you.
Yeah, Dr. Zakia, I'm very jealous. I like your RCA better than the RCA that I had. I like yours.
My patient was not a CABG patient. Your patient was a CABG patient. So probably they have very bad disease compared to the ones who don't have a post-open heart surgery. So
Yeah,
your RCA was a horrible RCA. Yeah.
Absolutely.
Horrible RCA.
Horrible RCA. So when I looked at that, and then Pankuri called me and she said that I have to record a live in box with IVL. And she'll always do it at the last moment. So I said, okay. I looked at this patient and I said, okay, I'm going to do it IVL in you. Okay. And so the rest of the people in the lab looked at me and they said, 3 lesions, 1 balloon. I said, yeah, 3 lesions, 1 balloon, and we're going to do it. That's all. Didn't have much choice in that case, but okay. We had a good time.
Yeah, very nice.
So is Dr. Jyotsna there?
Jyotsna is not there. Dr. Ritu is online. So she's.
Yeah, Ritu, any comments from you?
Wonderful case, Zakir. Loved it.
Thank you.
I can see Dr. Mamtesh Gupta is also on the panel. Dr. Mamtesh, would you like to make some comments?
The RCA chose you, Sarita.
Right.
Ma'am, can you hear me?
Yes, we can hear you, Dr. Mamtesh.
Hello, ma'am.
Hi.
All presentations were so informative and so nice, ma'am, and I loved all of these presentations. And I work in a very in a city, Meerut, that is quite nearer to Delhi. But unfortunately, I don't have any modality of imaging modality with me. I just depend on this fluoro and for looking with the calcium. And I've just done one case with IVL.
So how was your experience?
Yeah, ma'am. It was a very heavily calcified artery, and I have suggested them to go to Delhi. And I could see, I thought the lady had so much calcium that it looks as if she's already stented in the entire LAD, and she had critical narrowing, though it was not approaching up to left main. There was lesion were in LAD and LCX. So I used one IVL balloon used for because cost constraint was there. So I used this balloon for.
This you are muted again.
Sorry, because size of the LAD and LCX was almost the same. So I used the same balloon for LAD and LCX, and result was excellent, ma'am. It was the nice experience in itself. And
thank you, Dr. Mamtesh, for sharing your experience with us, and to everybody who is watching us right now. So imaging, when we have it, is an amazing modality. But if you don't have imaging, let it not deter you from doing these cases, because I've done a lot of cases of IVL without imaging also, with excellent results and excellent follow-ups. So if you have imaging, by all means, go ahead, use it. It helps you in the procedure. But you don't have imaging, don't let it stop you. The second thing is that in a lab like mine, where the lab runs till 12 o'clock at night and you frequently don't have time. So half the time, even when we have imaging, we don't use it because you got to cut the procedure short. So imaging is really good. It helps you. It gives you a very good idea of your results, of what you've missed, of how to plan your case. But if you don't have imaging, please don't let it stop you from doing these lesions. We have been doing them angiographically for a very long time, and we can still continue doing it. So ladies and gentlemen, that brings us to the end of our Shock Talk. We have exceeded the time by 21 minutes, and we've had a very lovely time doing it. It's been an amazing session, amazing set of cases were discussed, a lot of learning.
Hello?
Yes.
Ma'am, I want to know about your experience about OPN balloon.
Okay.
Touched in this session.
Dr. Mamtesh, is that you?
Opium balloon, ma'am. Opium balloon.
Okay. So yes, I do use a lot of opium NC balloon. The good thing.
Cross.
Hello,
ma'am. Can you hear me?
Yes,
we
yes,
can
we
hear.
can.
I have this in my this thing inventory, but I tried using this balloon in 2 of my patients, and unfortunately I could not cross. Because I don't have rota here, so these were unfortunately, because of the profile of the balloon, I could not cross it, and so I want to, ma'am, your experience.
Dr. Mamtesh, I have a very good experience with opium NC. But see, the first requirement of a balloon is that it has to cross. I don't know, it must have been a very tight lesion, because otherwise, opium has a very good crossability profile. It is specially designed to cross. So if you were not able to cross, then that means that those lesions are extremely tight and not amenable to a balloon crossing. Second thing is that it has a twin layer technology, so it can go up to a very high pressure without the risk of rupture. It usually does not rupture. I've not had a single opium rupturing, and I've gone up to like 40-45 atmospheres pressure. It doesn't usually rupture. And where I find it very useful is that I've put in a stent and the lesion has not properly expanded. And the patient does not have the liberty of using an IVL, because IVL comes at a cost. So that is where I usually take in an OPN and dilate inside the stent. So if my stent has not fully dilated and I can't use IVL inside the stent because the patient can't afford it, that's where I take in my OPN and I post dilate. And frequently I've got away with an OPN, where otherwise I would have had to take in an IVL. So that is the benefit of this balloon.
Okay. Thank you, ma'am. Thank you for sharing your experience.
Ankhuri, just before ending, I just had a very basic questions about IVL. So once you put the IVL balloon to a lesion, how far the ultrasonic waves travel? There are people who have talked about these waves traveling to another artery and causing damage in the other arteries. You know, there some of my male colleagues have presented cases like that. So I just wanted to know, how much do they travel? How far do they travel?
So Dr. Zakia, a very relevant question. So when we talk about lithotripsy waves, so they work on the principle of hard on hard and soft on soft. So they definitely, pass through the soft arterial tissue without damaging them. But, when we talk about the calcific plaque, they create microfractures in the calcium. So whenever you are using shockwave, be completely rest assured that it is an extremely safe therapy to be used in the calcific lesions. So no harm caused to the arteries so far.
So is it possible that if you use this technology in not very heavily calcified lesions, so like you're visually seeing more calcium, but internally there is not much calcium, and you use it and then the waves traveled and caused damage to other artery, can it happen?
No, it's not possible, Dr. Zakia.
Yeah,
it's not possible because it does not damage soft tissue. It will only, the way that it is built, the waves that are generated has no effect on the soft tissue. It will only hit the hard tissue and fracture it. So which is why it will not damage the soft tissue at all. That is why it has been so successful. It does not damage soft tissue. It has to reach a certain impedance for it to act. The waves which are coming react on that principle that only if it hits a certain impedance, and that impedance has to be as hard as calcium for it to work. Otherwise, soft tissue, it passes through unharmed. The second thing is, when you talk about how far these waves go, I have personally experienced that when I was doing IVL in the LAD, and there was a diagonal coming out of there, and there was ostial calcification in the diagonal, the calcium at the ostium of the diagonal also broke away. So the waves travel to some depth, but they only act on the hard calcium. They do not damage the soft tissue. So it's perfectly safe to use.
Because one of my colleagues had presented a case where he said that while I was doing a left main LED IVL balloon, there was a hematoma in the circumflex caused by the IVL. So at that point, I argued with him that it is probably your guide which got sucked in and caused trauma to your cervix rather than the IVL balloon. So he had cases like that. So I felt that it is more guide trauma than the waves traveling causing damage.
Fully agree with you. It's not possible that you're doing shockwave in the LAD and that shockwave therapy moves to the circumflex and damages the circumflex. It cannot happen.
Cannot happen. Yeah. Thank you.
Thank you, Dr.
And I'm just adding to Dr. Rao's point here. So, even in the CAT3 and the CAT pooled analysis data that we have for shockwave, so far in 629 patients, we have not seen any severe dissections or perforations in the data. So you can be rest assured that shockwave is an extremely safe therapy to be used in your patients, and shockwaves do not travel beyond 4 mm of depth.
Yeah.
So you can use it in any kind of patients, and all these patients in the pool analysis, Dr. Zakia, were even patients with the average calcium length of 48 mm with eccentric calcification as well.
Okay, thank you.
So thank you to all of the panelists, to all of the excellent speakers, and thank you also to the chairperson for a very enlightening evening. Excellent discussions and a wonderful way to start our Women's Week. Ladies only, I think. So thank you so much, ladies, and also to the gentlemen who are watching. Thank you.
It was really good connecting with all of you.
Yeah, very nice. Very nice.
Yeah. Same here.
Yeah.
Thank you. Bye.
Ritu, join for the WCC, right?
Yeah, Zakia, I'll be there.
Yes, to all the ladies here, please join for the WCC. It's your program and it has to be a good success. Yes. So welcoming all of you to that.
Yeah, we should all get together and make it a bigger success.
Yeah. Thank you so much.
Thank you.
Thank you so much for everyone for joining. Thank you.
Thank you.
Bye.
Thank you, ma'am.